So, as Glendy mentioned, I will be talking to you about some old foes and current tactics. I'm currently an ID physician, as she said, at the Massachusetts General Hospital, and I'm also an instructor at the Harvard Medical School. And that is my contact email if you need to contact me after this lecture. Okay. A second. I have no disclosures. And so I'd like to start with the first question that I posed to you all. Which pathogen has had the greatest comeback story of our time? And some of you may think, oh, it's monkeypox because that's been in the news a lot lately. Others may think because measles vaccination has gone down, that it may be measles. But I challenge us to think of syphilis, otherwise known as the great imitator, and to think of it in all of its forms, including primary, secondary, latent, tertiary, neurosyphilis, ocular and otic, and congenital syphilis. And these have really made a comeback. If we think about in the US, looking at their syphilis statistics over the years, in the 1930s and 40s, during World War II, you see there were some very high case rates of primary and secondary syphilis going up to 400 cases per 100,000 population. But by the year 2000, we were actually on a pathway as a global entity of eliminating syphilis. In fact, many organizations, including the World Health Organization, had various, let's eliminate syphilis by 2005 initiatives where the aim was to get less than 0.1 cases per 100,000 population or less than 1,000 cases per year. But of course, if we zoom in to what happened after 2000, the case rate went from around 2.1 per 100,000 and then gradually started climbing up. First place in the US was California, but over that, we see in the US by 2021, they had gone up to 176,000 cases for the year that were registered. There were some groups that deserve special attention, including congenital syphilis, where there was a 700% increase since 2010. Similarly, with men who have sex with men or men, MSM population, there's been a 700% increase. And then specifically in the HIV population, around 40 to 50% of men who have sex with men are dually diagnosed with syphilis and HIV. So the case rate in congenital syphilis is now around 2,000 cases per year. Similarly, the cases in MSM population have gone well beyond 14,000 cases per year. Other groups, women are also seeing a stark increase. This was just put out on the 15th of July, where women in Houston were seeing 128% increase in syphilis cases. And there are continued racial disparities where American Indian and Alaska Natives, as well as Black and African Americans, are facing the blunt of the burden. In the Caribbean, these were the latest statistics I saw from the 2019 to 2020 STD report from PAHO that showed that the syphilis seropositivity was around 1% in Bahamas, Cuba, Haiti, Jamaica, Panama, and St. Lucia, and about 1.4% in Dominica in 2020. Obviously, there are still some areas or countries that have disproportionately affected populations. So these were three countries that had available data. So Bahamas, they noted that 35% of their MSM population was positive for syphilis. Similarly, in Trinidad, around 16% of their MSM population was positive. So what did that mean, or what did that lead to with these very, very high rates of syphilis? There's been stockouts of penicillin, and that really started in 2017, where around 41% of countries around the world were noticing a huge stockout of benzathine penicillin G, otherwise known as Bicillin. And whenever there is a low supply and a high demand, what happens to the price? It goes all the way up. So particularly in the US, a course of three doses of penicillin is now around 3,000 US dollars up to 5,000 US dollars. Pfizer is expecting the return of adequate amount of penicillin by October 2024. But even once again, last month they posted, to make sure that we're aware of this looming penicillin shortage and that many places are unable to get penicillin to treat their syphilis cases. And once they're not treating syphilis, we expect an increase in transmission and further increase in the rates. So one can ask, like, what is driving this resurgence of syphilis? In the old days, people would say sex, drugs, and rock and roll. So, currently, the current cluster in the syphilis pandemic is azithromycin resistance, and azithromycin used to be thought of like a one-stop shop in terms of treating STDs. So if you had chlamydia, if you had gonorrhea and syphilis, people would often give like a one-time dose of azithromycin, but syphilis has become resistant to that drug. Also, there's been an increase in condomless sex after the promotion of pre-exposure prophylaxis or PrEP for HIV prevention. And that has led to an increase in STIs in the MSM population as evidenced by the Australian PrEP study. Budget cuts have also occurred in prevention programs, both in the Caribbean and globally, where around 40% of the budget that used to be directed toward STD prevention has been redirected to other funding. And then social media platforms have really blossomed over the years, including Grindr, Tinder, and Bumble, where there are high rates of STIs in the participants or users of these apps. And so if I were to say what happens or what's driving the increase now, I would change it from sex, drugs, and rock and roll to probably sex, drugs, and Tinder or Bumble. There is also a large intersection between drug use, like methamphetamine, cocaine, IV drug use with syphilis among heterosexual men and women. So the global target, as I said initially, was by 2005 to eliminate syphilis. Obviously, we have failed in that regard. And so the World Health Organization and other bodies have formed a new target to at least reduce the syphilis incidence by 90% by 2030. And similarly, to decrease the incidence of congenital syphilis to less than 50 cases per 100,000 live births by 2030. And so with that introduction, and I hope I have convinced you that this syphilis has made one of the greatest comebacks of our time, I think it's really important for us to just go over the natural history, the current case definitions, including the definitions for neurosyphilis, ocular syphilis, and congenital syphilis, some updates in the diagnostic testing algorithms and diagnostic dilemmas or challenges, as well as some updates in the screening recommendations and the take-home points. So syphilis, as we know, is a sexually transmitted disease caused by the spirochete, Treponema pallidum, subspecies pallidum, or TPA. It looks very pretty on this image, it's corkscrew, but it wreaks havoc on the body. It's transmitted from person to person through direct contact with a syphilitic chancre, and many chancres are unrecognized, so transmission may occur from persons who are unaware that they are infected. Transmission may also occur from mother to child. Syphilis has many disease manifestations, hence why it is called the great imitator or the great mimicker. Traditionally, it was taught as a continuum of manifestations after infection, where you went from primary phase, secondary stage, but now later on we're learning that people can go back and forth between stages, and it's not necessarily occurring on this one-way trajectory that was previously taught. Even when people are asymptomatic, they do remain at risk for late complications if not treated. So this is kind of where what most textbooks will show you. You're exposed, and then you go on to develop primary syphilis, secondary syphilis, then early latent syphilis, which has now been rebranded or renamed early non-primary, non-secondary syphilis to emphasize that latent is not really true, as people are still able to infect others during this time, and the bacteria is still replicating. So they're trying to remove the term latent from the nomenclature. Similarly, late latent is being branded late syphilis and tertiary. What we've learned is that neurosyphilis, ocular syphilis, and otic syphilis can occur anywhere along this spectrum, and not necessarily only as a part of tertiary syphilis. And so this is where some of the changes have occurred over the years. Primary syphilis, in terms of the definition, it usually occurs 10 to 90 days after exposure. It's characterized by a painless ulcer at the site of inoculation or infection. And so it can occur on the tongue. In the first picture here, we have a chancre on the dorsal aspect of someone's tongue. It can occur on the penile shaft or the glans penis. It can occur on fingers. Here we see someone, wearing finger condoms in order to prevent them from getting the chancres on their fingers. I'm not really sure how this person got a chancre on their abdomen, but guess we can be innovative in our thoughts. Areas that are not seen can also be areas or sites of inoculation or a chancre, such as the anus or the cervix. And so this stage is most infectious stage, and partners of individuals who are diagnosed with a primary chancre should be treated. Secondary syphilis tends to occur around 4 to 10 weeks after the appearance of a chancre. It's characterized by a local or diffuse mucocutaneous lesions. What we're most used to is hearing, a maculopapular rash on the palms and the soles. But bear in mind, there are other dermatological manifestations. For instance, it's figure 1. You have an annular red papule with some central clearing that almost looks like a target rash or a bullseye rash that people see with Lyme disease, but this was actually biopsied and found to be consistent with secondary syphilis. Similarly, it can appear like serpiginous, looking almost like ringworm or tinea, but once again, when this was biopsied, it was consistent with syphilis. Other signs include mucus patches or alopecia. This stage is also highly infectious, but can resolve without treatment. Now, to understand what the latent phase is, we must first understand the diagnostic testing of syphilis. So life would be a whole lot easier if syphilis was able to grow in the lab on an agar plate, like most other bacteria, but it isn't. It's extremely difficult to grow. And so we have to rely on other methods for diagnosis. And traditionally, the diagnostic algorithm for syphilis has been divided into direct test and indirect test. For the direct test, there are 3 main ones: the dark field microscopy of lesion exudates, where you're actually able to see this immunofluorescent looking spirochete on the dark field on a dark background. The other mechanism is electron microscopy and molecular diagnostics such as DNA or RNA PCR. However, those are reserved mainly for diagnosis of congenital syphilis or for research purposes. And what we tend to use most in our everyday practice is indirect serological tests. Now, the indirect serological tests can be divided into treponemal and non-treponemal tests. Treponemal are specific IgM and IgG antibodies to the Treponema pallidum bacteria itself. So these are very specific to the syphilis bacterium, whereas the non-treponemal antibody test detects IgM and IgG to synthetic cardiolipin. And so here I just have our balance beam. There are way more treponemal specific tests, including the hemagglutinin assay, or MHA, the fluorescent treponemal antibody test, or FTA-ABS, the treponemal pallidum particle agglutination, or TPPA, enzyme immunoassay, or EIA, and the multiplex flow immunoassay, or MFI. For the non-treponemal test, which is non-specific and is directed towards cardiolipin, you have the Venereal Disease Research Lab, or VDRL test, similarly the RPR, or rapid plasma reagent, and the toluidine red unheated, or TRUST. And these are, this is an example of the VDRL test that I used to do a lot of during my time at in the micro lab at UE, where you have someone's serum inoculated and you look for flocculations at the different levels of dilution. In terms of the timing of the serologic responses, or the serologic tests, what you'll see here on the y-axis is the percentage of patients with syphilis who test positive for these various tests. And on the x-axis, we have the time from infection onwards. So looking at the first line, which is IgM using the EIA or ELISA, that becomes positive within the first 2 weeks. So this is the first test to become positive, and it is a treponemal specific test. After 2 weeks, the second line, the green line, is the IgG to the treponemal specific test, so IgG FTA antibody test. After that, so around 3 to 4 weeks, that's when you start finding your non-treponemal test, specifically your VDRL and RPR, which are represented in this dotted line. And they continue to rise, but you'll see after around 2 years, many people start to lose positivity for VDRL. Even if they're untreated, it can become negative for around 40% of individuals who have had syphilis. If they're treated, it's more likely to become negative. But just to bear in mind that unlike the treponemal specific tests, such as the FTA or the TPHA, that remain positive essentially for life, the VDRL test, even if you're untreated, can become negative for around 40% of individuals that have had syphilis. And so that brings us to the question of which test is the best. People will say the TPPA is the best, which is a treponemal specific test, because it will pick up those early cases, 94% of primary cases in the first 2 weeks. It also will pick up early and late syphilis cases, and it's very specific. It has 100% specific. I know most of us are familiar with the VDRL and RPR, but note that it will miss at least 30% can miss 20 to 30% of your primary syphilis cases, because it's not going to be positive until around 3 to 4 weeks after exposure. It's very good for your early latent, but not that much for your late latent. And so based on those updates, in terms of understanding the diagnostic test, the US and many other countries have moved away from starting with the VDRL and the RPR, primarily because it could miss those early cases that are in the first 2 weeks of infection, and you can miss some latent cases because, as I said, 40% of people with syphilis, even if they are untreated, will become VDRL negative. They've also moved away from it because it's time consuming. The VDRL and the RPR usually have to be read by humans, and then they count the circles that have flocculations in there and report a titer. So it is time consuming, needs more manpower. And so in around 2004, many countries, including the US, switched over to automated tests that started with the EIA specific IgM and IgG to the Treponema pallidum bacteria itself. And then once that was positive, this is what they call the reverse testing algorithm, where if your EIA is positive, then they go on to do an RPR or VDRL titer at that point to give you an actual number, like 1 in 16 or 1 in 32. And then if that's positive, they'll say definitively that you're diagnosed with syphilis. And then you have to make a determination whether this is a past infection or if the person was treated. However, if the EI is negative, it could mean that the person is still incubating. If you have a high suspicion, you still treat it. So just to go back to latent syphilis with all of that information, the traditional definition for latent syphilis is if you have no symptoms, but you have a positive EIA or FTA plus a negative or low titer VDRL or RPR, and you've confirmed that you actually do have a positive treponema-specific test with a TPPA, then you have latent syphilis. However, as time has gone by, they've divided latent syphilis into early and late, where early is where the person has had syphilis for less than a year. And that's usually by them going through the patient's records and seeing that they've had a negative TPPA or a negative VDRL a year before, or it could be late latent where the person has had it for more than a year. In 2017, the nomenclature changed from early latent to early non-primary, non-secondary syphilis. And as I mentioned earlier, the rationale for this change was to remove the term latent from the surveillance stages to make sure people understood that during these stages, people are still infectious and can pass the infection on to their partners. It also was changed to highlight that some of the clinical manifestations, such as neurosyphilis and ocular syphilis, can occur during these stages. Similarly, for late latent, the nomenclature was changed to late syphilis or syphilis of unknown duration. And the case definition for syphilis of unknown duration or late syphilis is a person who has had no clinical signs or symptoms of primary or secondary syphilis, but they meet one of the following criteria. So one, they've had no prior history of syphilis or reactive serology. They've had a history of syphilis, but their serology has increased by 4-fold, or meaning their titer went from like 1 in 16 to 1 in 258 or something. And then they meet the criteria for neurologic, ocular, otic, or later clinical manifestations. Tertiary syphilis is now under the umbrella category of late syphilis. And so this is an entity that usually occurs around 10 to 30 years after being infected. Around a third of patients with untreated syphilis will develop this late sequelae. It includes gummas, which are just granulomas, and cardiovascular syphilis. Here we can see a dilated aorta, which syphilis tends to predominantly affect the aortic root and cause aortic root dilatations. It's something you should think of in people that are presented with a new aortic aneurysm. And neurosyphilis should not be confused with tertiary syphilis. They shouldn't be used interchangeably because it's two separate entities. This stage of syphilis, where persons have developed gummas to the face or aortitis, this is a non-infectious stage. So let's just clarify what neurosyphilis is. So neurologic manifestations of syphilis may occur at any stage of the infection. Animal models actually demonstrate that the Treponema pallidum bacteria disseminates to the CNS within hours to days after exposure or inoculation. Neuroinvasion should not be confused with neurosyphilis. They are two different entities, which I hope this diagram will kind of explain. So just going from the left to the right, left is the time continuum, where you're going from primary to tertiary or late syphilis. And then over to the right-hand side, we have the neurologic manifestations of syphilis. So as you can see here, from the time after exposure, which is time of primary syphilis, around 25 to 60% of cases will have CNS invasion, of which around 5% of those will become symptomatic with either rip-roaring meningitis, a cranial neuritis or cranial neuropathy, such as the seventh nerve palsy, ocular involvement, including vision loss, or meningovascular disease. And so that can occur anywhere along the 10 to 90 days up until the 10 weeks later, which is in the secondary syphilis stage. And then going on further in time, as we said, 5 to 30 years later, when people tend to develop late syphilis or tertiary syphilis, people can go on to develop either general paresis, which the onset is 2 to 30 years post-infection, or tabes dorsalis, which is involvement of the dorsal columns, and that occurs around 3 to 50 years later. The other division for the neurologic manifestations include neuropsychiatric. So, persons presenting with new onset hallucinations, delusions should be tested for syphilis. Meningovascular disease, as we mentioned, it can cause a meningitis or vasculitis, and myelopathic diseases. The concrete estimates of the prevalence of symptomatic neurosyphilis are lacking because there's no actual gold standard to diagnose syphilis. Most people are not doing a brain biopsy to test spirochetes. And so once again, we have to rely on these kind of indirect methods to diagnose neurosyphilis. So most of it is based on a combination of clinical findings and CSF findings, but sometimes we do use radiological findings to help us as well. So the CDC has a neurosyphilis case definition, which is like the slam dunk verified definition. If a person has a reactive non-treponemal test, such as a VDRL or RPR, plus a reactive treponemal test, such as an FTA or TPPA, with the following. So they have clinical symptoms or signs of neurosyphilis. So they have either weakness in a leg, bladder, urinary incontinence, they have some eye signs, and they have a reactive VDRL in the CSF, then they definitely have neurosyphilis. The issue is that the sensitivity for VDRL in the CSF is only 50 to 60%. So around 40% of the cases, 40 to 50% of the cases will not have a positive CSF VDRL. And in that case, you have to now end up saying, this is probably likely neurosyphilis and not definitively neurosyphilis. So they have clinical symptoms or signs of neurosyphilis, but their CSF VDRL is negative. What are some other additional data points we can use to say that this person likely has neurosyphilis? And this is where the other CSF findings come in, including the CSF protein, which tends to be elevated in neurosyphilis, as well as the CSF white cell count tends to be over 5 white cells per millimeter cube. In the absence of other causes, of course, of these abnormalities, you would say that that's a case of likely neurosyphilis. Some common questions with neurosyphilis include, can a diagnosis of neurosyphilis be made in the presence of a normal CSF exam? And I will say, particularly for ocular and otic syphilis, this can happen. So 40% of persons with ocular syphilis tend to have a normal CSF examination. Similarly, over 90% of people with otic syphilis, which is syphilis involving the air, tend to have normal CSF findings. Who needs a lumbar puncture? Currently, the CDC recommends that a CSF examination be performed in all persons that have serological evidence of syphilis, in addition to neurological signs or symptoms. So that includes people with headaches, people with cranial nerve deficits, motor deficits, sensor deficits. They should be evaluated with a lumbar puncture to analyze their CSF. Asymptomatic persons with syphilis whose serological titers do not decline by fourfold following appropriate therapy need a lumbar puncture because the CSF can actually act as a reservoir for continued infection or perpetuation of the infection. And so if you are treating them with penicillin and you treated them again with penicillin and you notice that their titer is not going down, think about it being the CSF being a reservoir and then probably needing like IV aqueous penicillin solution. People with HIV and syphilis, if their VDRL or RPR titer is greater than 1 in 32, and they have a CD4 count less than 350, it's now a plus or minus recommendation, meaning you can consider it. In the past, it used to be definitively that these people needed a lumbar puncture, but now the recommendation is more relaxed and based on shared decision making that they need a lumbar puncture. For ocular syphilis, the 2016 CDC advisory to clinicians stated that we should be aware of ocular syphilis and screen anyone with visual complaints and that have a risk for syphilis, particularly men who have sex with men, persons with HIV, persons with multiple partners. But as I had kind of alluded to at the beginning, it is increasing in so many populations. I would say that anyone coming in with a visual complaint this time should have a syphilis screen done because just the incidence of ocular syphilis has really skyrocketed over the years. And then if any other cranial nerve abnormality is found, then a lumbar puncture should be performed. One of the manifestations of ocular syphilis include like a conjunctivitis, which we're seeing here, this redness of the conjunctiva. In terms of a retinal exam, you can see these hard exudates as a part of the manifestation of ocular syphilis. For congenital syphilis, which is where you have mother-to-child transmission in utero, there's a wide spectrum of severity, and the manifestations are based on age, where if you are less than 2 years old, you tend to have manifestations including jaundice, hepatosplenomegaly, syphilitic rhinitis, which is referred to as snuffles. Whereas for individuals over 2 years old, they tend to present with like Hutchinson's teeth, saddle nose, and hypertrophy, symmetric hypertrophy, synovitis, which is known as Clutton's joints. And that's congenital syphilis, as I had mentioned before, is usually diagnosed by direct methods because the maternal IgM and IgG antibodies are transferred through the placenta. And so you may be picking up maternal disease if you're testing just for antibodies. And I will mention another note for congenital syphilis is that around 67% of babies that are diagnosed with syphilis as of last year are being diagnosed outside of the 1 month or neonatal period. And so it's pediatricians also need to have a strong index of suspicion. And the CDC has actually come up with multiple advisories and alerts as to how to stop this devastating surge in congenital syphilis, including improving the testing for pregnant women. You know, the Caribbean has a robust screening program for pregnant women in the first trimester, but I think where the Caribbean is lagging is repeating that syphilis test around 28 weeks or the third trimester, and that was a recommendation that had come out in around 2017. So just making sure that not in addition to the beginning of the pregnancy, that you repeat testing during the third trimester to pick up anyone who has acquired syphilis during their pregnancy and hopefully treat them before they can pass it on to the baby. Similarly, you want to treat their sex partner to prevent them from getting reinfected during the pregnancy. And penicillin is the only drug that's recommended for treatment in pregnant women. The other special population that I just want to highlight is the HIV and syphilis co-infection. because they are so often encountered together or presenting together, you really should bear in mind anyone that is positive for syphilis, you should be thinking about HIV as well. So if someone tests positive for syphilis, please to remember to ensure that they're getting tested for HIV, as HIV increases the acquisition of syphilis. It makes persons more vulnerable to syphilis and vice versa. In terms of the treatment, it's divided based on stage. So for early stage syphilis, which is primary, secondary, and early non-primary, non-secondary, which I just have latent on the slide, the recommendation is benzathine penicillin G, 2.4 million units as a single dose. If it's late, and we know that definition is been infected for over a year, then you should be using 7.2 million units of benzathine penicillin administered as 3 doses at weekly intervals. For pregnant women, the only drug of choice is benzathine penicillin. If they're allergic to penicillin, the recommendation is that they get desensitized rather than using an alternative agent. And then for neurosyphilis, including ocular syphilis and otic syphilis, the recommendation is a course of aqueous crystalline penicillin G for 10 to 14 days. And that's usually given as a continuous infusion. Now that there are so many stockouts of penicillin, the CDC has given this interim recommendation that we continue to use penicillin G for pregnant women, but if your organization and entity really has no penicillin for the other populations, you can use doxycycline 100 milligrams twice a day for 2 weeks if it's early syphilis, or for 4 weeks if it's late syphilis or syphilis of unknown duration, as an alternative for people where penicillin is out of stock, or for people with a penicillin allergy. In terms of how to define a cure, the CDC defines a cure as a 4-fold drop in your VDRL or RPR titer at 12 months after treating, or a 4-fold drop at 24 months after treating if it's late syphilis. You are defined as having serofast syphilis if you have persistent low titers, and this can occur in around 35 to 44% of people. So it doesn't necessarily mean that you have failed treatment, but if you've retreated them and they're still not showing a fall, as I said, first thing you do is do a lumbar puncture, because it could mean that they have a reservoir, but if their lumbar puncture is negative and you've retreated them several times and there's no fall in the titer, then this could just mean that they're serofast and will never get rid of their RPR or VDRL titer. Still, some of the take-home points for syphilis are: 1, have a high index of suspicion. Now that the cases are getting so high, you have to be very aware of the various symptoms and manifestations that it can have, knowing that it's not always going to be a genital chancre for the primary lesion, and knowing that it's not always going to be a maculopapular rash on the hands and feet for the secondary lesions. We look out for those abnormal skin manifestations, look out for hepatitis and various other manifestations that it can mimic. You also need to be able to interpret the new testing algorithm. So as I said, because VDRL and RPR can remain negative for the first 3 to 4 weeks, just because it's negative, it hasn't completely ruled out that the person has syphilis. You can either do a treponema-specific test, or you can ask the person to come back later on, like 2 weeks later, to repeat the VDRL or RPR testing and confirm whether they have it or not. So just being able to interpret the testing algorithm, and also being aware that some people may be serofast. And so if you've treated them already and they've been treated, you don't need to keep treating them. Similarly, you should have a high risk of, you should be in screening high-risk individuals such as babies, pregnant women, men who have sex with men, people with HIV, and people that have a substance use disorder. And don't forget to treat the partners, because if the partners aren't treated, they'll reinfect the original patient, and then you'll have this perpetual cycle of infection. For public health professionals, I think it's important for us in the future to think of better ways to prevent it. I know they've been working on vaccinations for a very long time, but it's been extremely difficult because, as I mentioned, just culturing this organism is extremely difficult. I think the vaccine trials have been done using rabbit testicular tissue, which is one place where this bacteria can grow more rapidly, but it's been extremely hard. But if we can think about new ways, especially with emerging technology to stop it, I think that would be very, very helpful. Public education campaigns where we are alerting the public of this increase and the various manifestations so that everyone is educated and informed, and making everyone on specific websites, dating websites, especially teenagers that may be on Bumble or Tinder, letting them know that there's a high population of persons with STIs on these dating websites. And then, just better ways to diagnose it, rapid PCR testing, just as how we can tell, how much HIV is in an individual and monitor therapy based on, those counts. We should be able to do the same thing for syphilis instead of kind of relying on these very indirect, difficult to interpret tests. And then making sure that we have joint HIV and syphilis testing. So it's a one-stop shop. You don't have to send one for the other, you send both at the same time. And wouldn't it be nice to have like a rapid biofire test where you have HIV, hepatitis B, syphilis, gonorrhea, and chlamydia, and it's just a urine dipstick? That would be great, right? And then you could know everything that was happening with the patient and treat them appropriately. So I think those are some things for us to think about in the future as these cases continue to rise. And here are some of my references. I'll stop here for questions in the first half.
Okay. Thank you so much, Dr. Pinkney. You have given us a lot of food for thought. Persons you can go ahead and post some of your questions in the chat. Very good presentation. You have really messed with our minds, let me tell you that, because honestly, there are some things that we just haven't been thinking about that, because we don't see it so often in the Caribbean, but I do think that cases are increasing. And so we have a lot of food for thought here. So I'll start with a few questions. What have you been noticing in terms of congenital syphilis? What's the most common presentation that you've been seeing, or have you been seeing any cases so far?
So I am in adult medicine, so I don't really see the pediatric cases, but what I hear from my pediatricians are that they're presenting with like the snuffles, so the rhinitis, syphilitic rhinitis, and some of them are presenting with those joint hypertrophy, like joint enlargement. That's what I've heard on the grapevine, but I'm not sure exactly what the most common pediatric presentation is. But I know that they tend to present more, or they're finding them, not that they present, but they're finding them more so after the first 28 days. So it's really astute pediatricians that are picking it up later.
So you've just answered the second question. At what age group are you finding these cases? And next question. What do you think in this day and age, when persons should know better, is the reason why we're still seeing these cases in some of our lower socioeconomic groups, persons from specific ethnic backgrounds, etc.?
I think it's, as I was mentioning before, it's kind of multifactorial. So even though you should know better, there are a lot of dating apps and a lot of sites now that are out saying, hey, this is a hookup site, this is Tinder, or we're just going to go out and hook up, especially when drugs and alcohol are in the mix, you may not be thinking about safety first. PrEP has been, one of the things, particularly the MSM community, that has been blamed for the uptick in cases because people are no longer using condoms or relying on condoms. They're relying on PrEP for HIV prevention. And so that has been associated with an uptick in cases. And I will say there's also in Jamaica, this emphasis, this lack of emphasis on syphilis as being an important STI that can cause or wreak havoc in terms of marketing or campaigning or public education campaigns. Particularly during COVID, the shift is towards COVID and preventing COVID. And so STI prevention didn't really get as much, was not as highly publicized as the other competing STIs.
Absolutely. And I do recall while working at Comprehensive, where, there is an STI clinic, a patient told me, "Doc, what's the problem? Why are you warning me about HIV?" It was HIV that I was warning him about. He said, "We'll just take the meds. We can live happy, healthy lives thereafter." So this thought process of using PrEP and not appropriately protecting oneself really is a cause for concern in this day and age. What do you think about syndromic management? I know I may be coming off base a little bit there because you mentioned that azithromycin resistant strains were on the rise as well. How do you think syndromic management plays a part in that, and whether or not this is something that should be continued?
Yeah, I think syndromic management can be continued if you're using the appropriate agent, especially if you don't have a lot of diagnostic capacity available. If you have a high index of suspicion and they have multiple treatments, the key would be to avoid azithromycin, because not only is syphilis azithromycin resistant, now there are different types of chlamydia and different types of gonorrhea. Everything is kind of resistant to azithromycin at this point in time. So it's just about what agent you'd be choosing. Doxycycline has still maintained some activity against syphilis, and so just incorporating that if you are choosing to do syndromic management.
Okay. And what do you think are there any IPC procedures or practices that should be put in place for persons who are in hospital with syphilis?
In terms of, not that I'm aware of, not that I'm aware of. I'm not sure if you have more information on that, Glendy. I don't have a protocol for that, but
not something we think about, but when you think about these chancres occurring on body parts that we don't tend to think of, then maybe
right.
we should be, put some
Thinking about
that thought.
That's true.
There.
That is true. And once again, it comes down to just having a higher index of suspicion, because people may see finger lesions on the fingers and not know, that this may be a contagious syphilitic lesion. And so I think the key there is not infection control per se, but just more increasing awareness.
Yes.
Increasing awareness of how different conditions, specifically syphilis, may manifest.
All right. And I think my last question, I think there's one on the screen that I'll go to soon. You mentioned that to indicate cure, persons should come back within 12 months, depending on the stage you're at, 12 months or 24 months. Do you find that patients return to get tested? That's a long.
Yeah. So when I was working at CHERS, that's the HIV clinic, we actually retested them every 3 months because the recommendation is that 3-month intervals for 12 months. And I would say they were pretty compliant, because were coming for the antiretroviral treatment anyway, right, and lab work for that. So I haven't seen, where people defaulted from care for coming back, because it is every 3 months for that first 12 months.
All right, awesome. So it was more of a comment that was presented in the chat, where Dr. Walker mentioned that it was an excellent presentation. I totally agree. excellent primer on syphilis, and he wanted to comment that the UHWI laboratory will be introducing syphilis testing by CMIA, and will be offering combined IgG and IgM treponemal results, testing and results, and using this reverse testing algorithm that you've mentioned.
Yeah, I do think that that's a good shift, because as I said, you'll be able to pick up more people in that 0 to 3 week post-exposure period that the VDRL and the RPR can miss. So I think it's a good shift, and it's not as labor intensive where we're not counting the flocculations on the cards anymore.
Yes. Awesome. All right. So if there are no more questions, we're going to allow Dr. Pinkney to move on to the second piece, or the second half. I'm so excited because this is going so great. The second half of our presentation. So without further interruption, go right ahead.
All right. Let me share. Second. Okay. So the second half of our presentation will be on extraparenchymal neurocysticercosis. And unlike the last presentation, I'm taking a little bit of a different format for this one, where I'm going to start with a case, because I think is best demonstrated with going through the clinical presentation. And then once we go through the case, we can talk about the extraparenchymal neurocysticercosis, including subarachnoid neurocysticercosis, the clinical presentation, the diagnosis, and the treatment. So our case is that of a 50-year-old female who had presented to the hospital with a 4-day history of headaches. For her history of presenting complaint, she had this acute onset global headache, which she said started while she was lying down in bed. She rated the headache as a 10 out of 10 in severity, and it was associated with photophobia, phonophobia, and some mild neck discomfort. She denied any vision changes, denied confusion, nausea, or vomiting, denied a fever, rash, or any ill contact. Her past medical history was significant for having neurocysticercosis around 6 years prior. She also had a history of latent tuberculosis that wasn't treated, hypertension, asthma, and obesity. In terms of her neurocysticercosis history, she was diagnosed in 2002 and again in 2009, and those details are unknown, but we were able to get her 2014 records, which showed that she had presented to an outpatient infectious diseases provider in Florida with similar history of headaches. At that time, she was prescribed prednisone and albendazole, but she never actually filled the albendazole. No fault of hers. There was a lot of going back and forth. In the US, you'll hear about this whole prior authorization nightmare. So there was, like, she couldn't get it authorized, couldn't pay for it. It wasn't covered by insurance. 2 months later, she was admitted to a hospital in Florida with the headache, had a CT head done, which showed some calcified structures in the pineal gland region, as well as obstructed hydrocephalus at the level of the cerebral aqueduct, and complete effacement of her basal cisterns. She had no neurosurgical intervention at that time, but had started albendazole in the hospital and continued her prednisone. In total, she completed around 1 month of albendazole and 3 months of prednisone and had resolution of her symptoms. So she remained off treatment for around 6 years. And so now she's presenting to us with this sudden onset headache. The rest of her history is not really exciting. You know, she's had a thyroidectomy, she's had a C-section. Her medications included Tylenol, ibuprofen, metformin, nothing exciting. She's allergic to penicillin. Her social history, she was born and raised in Haiti, moved to the US in 1999, and then she lived in Alabama. for a while before moving to Boston, and she's married, and she works as a patient care assistant at one of our medical facilities. On her physical examination at the time of her presentation, she was not toxic appearing, like she was well appearing. Her neck was supple, she had no rigidity. Her respiratory system was fine, abdominal system, skin exam was also normal. And for her neuro exam, she was alert, she was oriented to time, person, and place. She had no cranial nerve deficits, and she had full grade 5 out of 5 power throughout. Her initial labs, her white cell count was normal, and her absolute eosinophil count was also completely normal at 290. Her CMP, which we call comprehensive metabolic profile, was completely normal, including her LFTs. And then her micro came back positive for a blood cysticercosis antibody, IgG, and her IGRA was also positive. For her imaging, her initial MRI brain was reported as having no acute abnormalities, some ventriculomegaly or enlargement of the ventricles, chronic white matter changes. But after getting her lab results, including her micro back, we asked the radiologist to do a second look, and they actually looked at a specific sequence of MRI called a Fiesta. And it was there that they were able to visualize these small cystic structures in the pre-medullary cisterns and so if we look at this as being the pons in the pre-pontine area, you also see a very like oval shaped cystic lesion there. The rest of her MRI spine had no additional cysts. She had an MR angiogram, which showed that she had a right internal carotid artery M1 junction aneurysm that was measuring around 3.4 millimeters. She had a lumbar puncture done, which had severely elevated white cells of 555 white cells, of which 27% were eosinophils, which we know is an eosinophilic meningitis. The glucose was also very low, 43, and her proteins were elevated at 71. So at that point, she was diagnosed as having neurocysticercosis extrapyramidal. She was started on high-dose dexamethasone, and that had led to resolution of her headaches. She was empirically treated for strongyloides with ivermectin. She declined latent TB treatment. Neurosurgery, neurology, and infectious diseases were following her up because they were unsure if her presentation was due to treatment failure from her previous 2014 treatment, or if it was due to rupture of an existing degenerative cyst. The initial plan was for her to get an endoscopic third ventriculostomy. However, that was canceled due to some technical difficulty, and she was actually discharged without steroids or antiparasitics because neurosurgery, neurology, and ID were all still contemplating whether this was treatment failure or if this was actually a new meningitis. 1 week later, however, she represented with the same headache, and this time actually had hydrocephalus, had to get a ventricular peritoneal shunt or VP shunt placed, and she was discharged on high-dose dexamethasone. I had seen her in the infectious disease clinic at that time, and we decided to start her on treatment for her latent TB, as well as Bactrim for PCP because she was on high-dose dexamethasone prior to starting her antiparasitic treatment. On the 16th, she had an ophthalmology exam where no intraocular cyst or papilledema was found. And then by the 20th, that's when she had started her antiparasitics. And I will say that the reason the antiparasitics were deferred were because we were waiting on this opto exam, because you really want to make sure there's no papilledema or intraocular cyst before starting the antiparasitic agent, as it can cause a lot of inflammation and eventually lead to blindness if this is if you start antiparasitic agents before getting enough immune suppression with dexamethasone. So that leads us into our discussion on extraparenchymal neurocysticercosis. And there are really two main guidelines that talk about the diagnosis and treatment. You have the IDSA, or Infectious Disease Society of America guidelines from 2018. And you also have the World Health Organization 2021 guidelines. I will be focusing on the IDSA guidelines just because of where I was located during this case. So with the IDSA, in terms of the diagnostic algorithm, you have the division of neurocysticercosis into extraparenchymal, which means outside of the brain tissue. So it's not in the cortex, it's not in the actual meat of the brain, it is in the ventricular spaces or extraparenchymal space. So you have the intraventricular, subarachnoid, could be in the spine, or it can also be ocular. In terms of just reminding us about how the ventricular system works, here you can see you have lateral ventricles that condense into the third ventricle, and that goes out through the cerebral aqueduct, which is this little pathway before it gets to the fourth ventricle, and then it goes, the CSF flows further down the spine, but some of it also gets redirected to the subarachnoid space, where it is reabsorbed by the arachnoid granulations. And so when we think about the cysts and where they are along this pathway of the flow of CSF, can see if they get stuck in any of these areas, it can subsequently lead to hydrocephalus and increase, basically a backup of fluid. Oh, and also you can see, because the CSF is in continuum, or adjacent to the optic nerve, this is why ocular syphilis is considered a part of the extraparenchymal neurosyphilis, because it's basically bathing the optic nerve at that point. So the subarachnoid cisterns, or the basal cisterns, there are three main ones that we want to think about. You have the premedullary cistern, which is around in this area, and then that's anterior to the medulla. If you remember just from basic anatomy, you have the midbrain, you have the pons, and then you have the medulla oblongata. And so the premedullary cisterns would be this space before the medulla. They also have the carotid cistern, which contains parts of the internal carotid artery. And so that's why people tend to get aneurysms of the internal carotid artery, because it's bathing those vessels. The cysts are coming in contact with those vessels through the carotid cistern. And then the suprasellar or chiasmatic cistern, it surrounds the optic chiasma, and therefore the optic nerves can be implicated. And then, so the subarachnoid neurocysticercosis, otherwise known as racemose cysticercosis, it occurs in around 5% of hospitalized cases. It's the most severe form of neurocysticercosis because, as I said, any obstruction along this pathway can lead to hydrocephalus. So it is the most severe form of neurocysticercosis and can increase the risk of death by around 16%, versus if it was parenchymal, there's around a 1.8% risk of death. The racemose cysticercosis is a subset of subarachnoid cysticercosis, where you have the cysticerca without scolex and a cluster, looking like a cluster of grapes is what they describe it as. So the clinical presentation, you typically have communicating hydrocephalus, where people present with just signs and symptoms of raised intracranial pressure. So they have headache, nausea, vomiting. They may have altered mental status, decreased visual acuity. And then they can also present with signs of chronic arachnoiditis at the base of the brain. And remember, I was showing you the base of the brain where you have these vessels running through. So they can present with a vasculitis of the internal carotid artery, aneurysms. Whenever you have an vasculitis or an aneurysm, it's a setup for a stroke. So they can present with stroke, seizures. They can present with meningitis and cranial nerve palsies, because you can also see the cranial nerves, like cranial nerve 4 and 6, the abducens nerve running through that area. In terms of spinal neurocysticercosis, there's a strong association of basal subarachnoid neurocysticercosis and spinal cysticercosis. And that's why they really advise that if you diagnosed it in one place, you get an MRI of the entire spine, and not just focus on that one area. And then all patients with subarachnoid disease should also undergo an MRI of the spine. For ocular neurocysticercosis, which is the thing we were kind of afraid of before we started antiparasitic agents, it's important to identify, because once you treat it, if this erupts or releases its inflammatory agents in the eye, it can lead to blindness. So the diagnosis of extraparenchymal neurocysticercosis is based on imaging, serology, and most recently they've added the Taenia solium PCR and antigen testing. So for imaging, as we saw with our case, standard MRI may actually miss the subarachnoid cyst, and because the cysts in those locations have a signal intensity that looks really similar to CSF. And so you have to, if you have a strong index of suspicion, speak with your radiologist about performing Fiesta or fast imaging, employing steady state acquisition films or sequences. And this will be able to show the cyst differently from the CSF. Similarly, there's a 3D constructive interface in the steady state that is able to show the cyst more clearly, or a balanced fast field echo. If you compare the sensitivity of the different modalities, the Fiesta sequences are around 87% sensitive for picking up the membrane of the parasite, versus just like a regular T2 or FLAIR MRI, where the sensitivity is all the way down to 38% for FLAIR and 17% for T2 images. For the T-solium PCR and antigen testing, serology doesn't differentiate between active and cured disease, which was the back and forth discussion neurosurgery, neurology, and ID was having at the beginning of our case, because the IgG was positive. It didn't indicate whether or not this was just representing old disease or whether this was responsible for her current presentation. And so because of that, they've come up with these new methods, such as the PCR and the antigen test, to try and improve distinguishing active disease from cured disease. So the T-solium R13 identified as a highly abundant repetitive sequence in the T-solium genome. It doesn't cross-react with other Taenia species like Saginata. It doesn't cross-react with Schistosoma or Echinococcus. So it is actually very useful to use for monitoring and diagnosis in these cases of neurocysticercosis. This is a study that looked at the CSF PCR, the Taenia solium PCR in 43 patients, and they actually, for patients that had pair samples, all had a detectable T-solium ddNA, which it is represented by having a cycle threshold less than 40 during active disease that eventually became undetectable at the time of cure. A cycle threshold just means, how many times you have to run the PCR for it to become negative. And so the more times you have to run it, I'm sorry, this is the inverse. So the more times you have to run it for it to become positive it means you have more disease burden or more infection burden. So in these cases, it going from a lower number or lower cycle threshold value to a higher value means that the burden of disease is becoming less and less over time. And so that's how they determined that the CSF PCR was a good marker to test for cure or during monitoring to test that your treatment is working. When they compare this to the antigen, so they're comparing PCR to antigen testing, where the antigen tests and the PCR tests are actually 100% sensitive in the CSF during active phase of disease. And it was actually pretty good for cure as well. It's not as great as PCR, like the PCR, 93% of them will be negative at the time of cure, whereas for the antigen, only 80% of them will be negative at the time of cure. But they're still pretty good, 80 to 93% negative at the time of your cure, even though PCR supersedes the antigen test. Similarly, in the plasma, PCR is better than antigen, but not by far. So I think the take-home point is that both of these are good to distinguish active disease from cure disease, because if you're already treated, most times these will be negative in both the CSF and the serum. So in terms of the treatment, it's typically divided into medical and surgical. So the medical treatment, you first want to decrease your inflammatory response to the cyst by using steroids or steroid-sparing agents. And then to actually treat the cyst or treat parasite, you want to use dual antiparasitic agents. For the surgical treatment, if possible, you want to remove the cyst if it is causing obstruction. So endoscopic management and open microscopy is used to remove cysts if possible. And if you're unable to move the cyst, other people use just VP shunts to manage the hydrocephalus or raised intracranial pressure. So the medical treatment, steroids, it's anti-inflammatory therapy, such as high-dose corticosteroids, should be initiated prior to starting the antiparasitic drugs. And the inflammatory response which occurs after starting the antiparasitic therapy can result in worsening hydrocephalus or stroke if it's not adequately covered by steroids. The steroid-sparing agents that are used to treat neurosyphilis, if someone can't tolerate high doses of corticosteroids, include methotrexate and include some of the newer anti-tumor necrosis factor alpha agents, such as etanercept or adalimumab. In terms of the dual antiparasitics, it's kind of the cysticidal efficacy is present when there are over three or more cysts present. And that's when they really encourage you to use 2 instead of 1 antiparasitic agent. So instead of just using albendazole alone, using albendazole plus praziquantel was found to have a higher cure rate of 68% in people with 3 or more cysts present. And so that's where that recommendation came from. In terms of the duration, patients with subarachnoid disease required a longer time of antiparasitic therapy. And this may be one of the reasons our index patient didn't do well in 2014, because if you recall, she only got 1 month of albendazole. That might not have been enough if she already had subarachnoid cysts present. So some ranges here go from like one from half a year to over a year. It's a wide range, but it definitely isn't 1 month. In terms of surgical treatment, untreated hydrocephalus is a contraindication to antiparasitic therapy. So you want to make sure the person has a VP shunt or something else to manage their hydrocephalus, because once you start the antiparasitic treatment, expect increasing inflammation, increasing hydrocephalus. What are the endpoints that you look for to make sure that your treatment is working? 1, you look for resolution of the cyst on MRI. So you're going to plan to repeat this person's MRI every 3 to 6 months to make sure the cyst have gone away. You want to look for resolution of the CSF pleocytosis, so making sure that CSF white cell count is coming down, and want to make sure there's improvement in the CSF PCR or the CSF antigen testing. So using those criteria for the index case that was presented, where the bottom right is or initial picture where we could see the 2 cysts in her premedullary cistern, over time, you can see that those cysts actually kind of disappeared, which is the top left-hand image where they're no longer present. And then in terms of her CSF white cell count, went from being 555 to 22 7 months later, with normalization of her protein and normalization of her glucose. Her CSF neurocystic sarcosis antigen went from being 3,744 to 0. And her neurocystic sarcosis PCR actually was not above 40 by this time, by October. So we ended up extending her treatment to a year, which was March of 2022, and repeated her CSF neurocystic sarcosis PCR. At that time, it was above 40, which is indicating that the cystic sarcosis is negative in the CSF. So in summary, I will say that, like syphilis, you have to have a high index of suspicion for neurocystic sarcosis in immigrants from endemic countries that are presenting with headaches and signs of raised intracranial pressure or even strokes. So this should be on your differential. Similarly, it may be difficult to diagnose. So just because the person has a normal MRI doesn't mean that it's completely negative. Make sure you're speaking with your radiologist to get those sequences, such as the Fiesta sequence, that can really help to visualize and distinguish the cyst from its surrounding CSF. With this new diagnostic test, the CSF PCR, it's very helpful for both distinguishing active from cure disease. So it's great for diagnosis and it's great for monitoring, because at the end, when the person is completely treated, it should be negative, just like the antigen was 0. So both the PCR and the antigen are good tests for diagnosis and monitoring. And then at the time of diagnosis, make sure you screen for things that can reactivate with high dose steroids, including tuberculosis, strongyloides. You want to also screen for ocular cysts and spinal cysts, because once those are present, you want to make sure they're reduced in size before starting your antiparasitic agents. And then the management involves both medical and surgical management, requires a very prolonged duration of steroids and combined antiparasitics. In our case, we went for a year of steroids and combined albendazole and praziquantel. But sometimes it's even more than that. You have to, once again, look at your imaging and the various biomarkers. So with that, I will again stop sharing.
Hey, Thank you again, Dr. Pinkney. That was another interesting case right there. And every time I wrote down a question, you answered it. So you made this section a little bit more difficult for me. However, can you remind us again, how do persons get neurocysticercosis versus cysticercosis?
So, tinosolium is ingested, usually by eating pork. That's the main modality that
Undercooked pork. Let's make sure we
undercooked pork, because it tends to the cysts tend to live in the musculature of this this animal, or species, for species. So that's the main way to ingest it and get the parenchymal neurocysticercosis.
All right. And we want to make sure persons are cognizant also that the pig would be an intermediate host. So we'd probably tend to more so get cysticercosis in the tissues from eating the undercooked pork. But when you have a serious problem of being more so exposed to neurocysticercosis is when we become the intermediate hosts and actually, ingest something contaminated with human feces, from a person who is actually infected and passing out the eggs in their stool. And we end up with the cysts that would have been in the muscles of the pig now in our brain tissue, and extraparenchymal and parenchymal disease that you're mentioning today. So thank you for that. I was going to talk to you about the dual antiparasitic therapy as well, but then you did kind of mention to us that the higher the load, and
they use three cysts as the cutoff.
Yeah. So that's very interesting to me, because you do see good cure if you do have a low
burden, but for people with her, where she had 3 cysts in the basically ventricular space, then
right.
she really needed dual antiparasitic agents, and that's what's been proven to have the higher chance of cure in a side-by-side study.
And has it become any easier for persons to get certain agents? You mentioned that for her, she didn't get her albendazole because of some issue with drug availability based on insurance. Has that become any easier in the US since this case?
I wouldn't say it has become easier. I would say it's very state by state dependent. So Florida, I think, still has a lot of restrictions in terms of what people on Medicaid or Medicare are able to afford, or if what their health insurance will cover. And so Massachusetts is more, I guess, liberal in literally speaking, in terms of the coverage that it provides for their Medicaid recipients to cover certain types of drugs and medications. So it's very state by state specific in the US. I'm not sure what the barriers are in Jamaica, but I'm assuming it will be much easier to get in Jamaica than in the US.
I mean, we do, complain about free healthcare and what it may be doing to the pockets of, let me say, the pockets of the government people. However, once the drug is available, you can get it through the programs we have available here. So that's a plus for us here in the Caribbean.
Yes, it is.
It absolutely is. And you had mentioned some about the blood tests and the fact that, of course, it doesn't really help to differentiate between somebody who was previously infected or with active disease. Can you just bring that point home again for us? I mean, we have a lot of the fiestas and all of the higher technology. So we'd have to work with what we have. I don't even know if we have the blood tests available in Jamaica. And it's a good thing that we overcook our meats here, So we don't tend to see these cases, but people travel and you may come across a case. So it's important to know what exactly to do. So just bring that point home again for us about the testing.
Yes, and so in our in our index case, just to reiterate, the first test she had was the neurocystic sarcosis IgG from her serum or her blood, and that was positive. But the dilemma is this positive because she's been diagnosed in 2002, 2009, and again in 2014? So is it representing just her old disease, or does she have active new disease going on? And so the cystic sarcosis IgG is not able to distinguish between active or old previous disease, which is where these other serum and CSF tests come in. The two which we utilized here were the PCR, near cystic sarcosis PCR test, and the other one was the T-solium antigen test. Those two can be used on both the CSF and the serum, and they're very good for distinguishing active disease versus cure, because they really should be negative at the point of cure. You should no longer detect it, but it would be very high titers at the time of diagnosis or infection.
Okay, thank you so much. I'm seeing persons commenting on the fact that it was another excellent presentation, another excellent lecture. So we're very grateful to you. We want to say thank you for this presentation. At this time, I'll actually open the mics. If there's anyone, let me know if you want to make a comment. I can go ahead and open the mic for you if you want to ask a direct question related to the topics we've discussed today. All right, I'm seeing silence. Okay, oops, Dr. Toms. Okay, 1 second for me. I think I've opened up the wrong thing. There we go. So give me a second, let me allow you to speak, Dr. Toms. Boy. Here we go. All right, you can go ahead and unmute. There you go.
Awesome. It's thank you so much. It's more of a comment. I'm hoping we can have Dr. Pinkney more often. I was thinking to myself, oh, for the sake of pork, is there a place for screening, both in terms of our meat agriculturally as well as for, occasional screening of the population? But as you said, we're not really clinically seeing the cases, so that's encouraging. Thanks, Dr. Pinkney.
Thank you, Dr. Thomas. Always helpful comment.
All right, any other comments or questions for Dr. Pinkney?
Good afternoon, Dr. Reynolds. Can I speak?
Yes, go ahead.
Dr. Pinkney, sorry, excellent presentation, both. Thoroughly enjoyed both. What I'd like to know is, with your neurosyphilis, you said if they got a positive non-treponemal plus a treponemal, and there's signs and symptoms of an infection, it is positive. Suppose it had a negative non-treponemal test, right, and a positive treponemal test with signs and symptoms, what would happen? So what would be the diagnosis?
Yeah, that would put it in the likely category, instead of the definitive or verified category.
Okay.
All right, great question. Anybody else had any other question they wanted to ask?
Okay, good afternoon, everyone.
Afternoon.
Very excellent presentations. Can you remind me, when we're doing the desensitization, like you have a pregnant woman with syphilis and your only option is the penicillin?
Yeah.
Can you just remind me of the process of how it is done?
Yeah, so these people have to be admitted to the intensive care unit because they're going to be basically exposed to increasing doses of penicillin dilution. So the first dilution is usually 1 in 100 of the penicillin dose, and over time they rapidly give it like every hour. So they go up from 1 in 100 to 1 in 90, 1 in 70, 1 in until they get to the full dose. Obviously, people have to have epinephrine and the other anti-allergy or anaphylactic medications on board, but it is slow incremental increases in the penicillin dose until you get to the target dose.
Okay, thank you very much.
Thank you.
Right, excellent question. Anybody else with any other questions at this time? Going once, going twice. All right. So at this time, again, I want to say thank you so much, Dr. Pinkney, for these excellent presentations. We had a great time. We stuck around. We learned a lot. We were reminded of a lot. And it has given us a lot of food for thought in terms of how we go about diagnosing that high index of suspicion that we have to have for these disease processes that haven't been around for a little while. So we tend to think we're safe. But with travel, I tell people a mosquito doesn't care. It likes airplanes. You know, a person can be in Zimbabwe in the morning and in Jamaica by evening. It doesn't matter. So we have to have that high index of suspicion. And these diseases are right next door. So, you know, we have to pay attention. We just had an influx of persons from a particular country land on our shores not too long ago. So these things happen all the time where persons come in, sometimes unbeknownst to authorities. So it's something that we have to keep in mind, both disease processes here and all the others that tend to.
1, 2, 1, 2, 1, 2.
I think you got muted a while ago, Glenda. We were hearing you.
The PowerPoint, so that if you want to, for the high-tech one amongst us who want to scan the QR code, I'll put that up as well. Let me help you there. All right, hope you're able to see it. Let me make it bigger for you. There you go. So you can either click on the link that's in the chat or scan the QR code that's actually on the screen. It will take you to the survey, very, very short survey, just a few questions. And if you need CMEs, you can request them using the very link. All right, so that's it for us for tonight. But join us again next week, Monday at 6 p.m. Jamaica time. We'll be looking at molecular and immunological diagnostics. Dr. Tiffany Butterfield will be our lecturer for that day. On the 31st, we're going to be looking at laboratory identification of parasitic pathogens. Now, this is a refresher course for all my technologist friends online. You know, some of us not looking at the parasites so much, and some persons actually say we're not seeing them anymore. But look at it, neurocysticercosis, huh? All right. On the 8th, and this is the only class that will be on a Tuesday instead of a Monday on August 8th, because we have a public holiday on the 7th, and I figure some of you just want to relax on the 7th. So on the 8th, we'll have IPC for the laboratory and beyond. That will be presented by Mrs. Catherine Vogel-Johnson. She's an IPC consultant from PAHO. She will also present to us on the 14th, which is the following Monday, on the hospital-acquired infection surveillance. She's also an excellent speaker. We have all our speakers are excellent speakers and teachers and lecturers. So I look forward to a very interesting couple of weeks coming up. And I invite you all to join us again as we share with you. I'm seeing a comment in the chat. Let me make sure that we've covered everything. Okay, so Dr. Pinkney has placed her email in the chat as well. So if you'd like to copy that, get in touch with her at any time to ask any questions, that would be awesome. Dr. Thoms had asked if we're going to make the presentation available. Are you willing to share your PowerPoint with us?
Yeah, I can share it.
Okay, great. So I will actually send that out to the persons who are present today through their emails as well. Thank you so much again, Dr. Pinkney. And to everyone, I say good night and see you again next week. Bye.
Thank you.
Everyone.